Hey guys, Michael here. This video is to do with needle thoracostomy or needle chest decompression. Now, tension pneumothorax is a life-threatening condition that develops when air becomes trapped in the pleural cavity under pressure, and this is what creates the tension. A progressive buildup of the pressure can obviously collapse the lung. It causes a shift in the mediastinum and obstruct venous return to the heart. This in turn obviously leads to a compromised cardiopulmonary function and may result in a cardiac arrest. The indications moving forward from that for a tension decompression, any single tension pneumothorax with respiratory, cardiac and or hemodynamic compromise. So any a primary survey compromise A, B or C, you want to decompress the side that you feel is injured and is causing the insult. Any chest injuries with major trauma where a patient is in a peri-arrest state, it's indication to decompress bilaterally, and in this state, if this is the case, you want to make sure you decompress the most injured side first. Moving forward from indications, we have a few bits of equipment that are required, which I'll put the picture up now. And these pieces of equipment are all used and will be shown in the video moving forward. Key considerations to remember is that once the chest has been decompressed, the catheter is not to be removed, and if like I said previously, if bilateral chest decompression is required, always go for the most injured side first. In your major trauma patients, if they have significant chest injuries, they may be experiencing subcutaneous emphysema as well. Using the hand to push away that that's trapped underneath the skin is going to allow you to make your physical landmarks a lot better and allow for you to ensure that you're inserting the catheter at the most appropriate point. Patients that are smaller in size, less than 50 kilos, smaller children, you've really got to be careful about the depth at which you actually insert the catheter and really make focus of the clicker that's in the pneumofix, so that as soon as you do get through that chest wall, that you've seen it, you've clicked it, and then you can advance it as no further than that, apart from as is required for the skill. You have to make sure that you're continually re-evaluating the cannula and the site to make sure that firstly the patient's not retensioned, it's not occluded, it's not obstructed, and this is the way that you want to make sure you're double checking for possibilities of retensioning, or if it's not been as effective at first stage, if you feel it has been. With the Russell pneumofix, you don't have to use a Heimlich valve or a connecting tube. It's already built into the casing goal itself, and using a scalpel is going to make it a lot easier for you to get it through the skin and those first few layers of structure. In terms of documentation, you want to make sure that you've noted down the time at which you've inserted or you've performed the decompression. If the cannula's had to be removed at any stage for some reason, you need to make sure you document the exact time it was. You want to make sure that you've noted down where on the chest the cannula was initially inserted, and that is obviously passed on and transfer occur onto the doctors and nurses that you'll be handing over the patient to. Vital sign trends, so it's including doing vital signs before, during, after the assessment, during the intervention rather. So obviously if you've got your partner or other people on scene that can assess you in doing that, and make sure that you can track the effectiveness of this intervention. So at this point, what we're going to do is identify the point at which we are actually going to insert the Russell pneumofix. Now to do this, we need to identify the midpoint of the clavicle. So on the patient, obviously we can't see the ribs on a real patient, so we're going to actually palpate the clavicle itself, find the clavicle, find halfway, and we have a midpoint of our clavicle. We can then draw this imaginary mid-clavicular line that goes down the side of the chest. Keeping that in mind, then going to move on to the second intercostal space. So on patients that have quite a pronounced angle of Louis, we can palpate that. That's the point at which the second rib joins the sternum. Beneath that is the second intercostal space. So if we draw a line from the second intercostal space across, and then combine this with our mid-clavicular line just above the third rib, to avoid the neurovascular bundles, we're going to mark an X. And this is the point at which our Russell Pneumafix is actually going to be inserted into the chest. So for the actual insertion of the Pneumafix, I've obviously donned my personal protective equipment. My gloves and goggles are currently on. First things first, I'm going to swab the site and allow that to dry for a good 5 to 10 seconds. Using a scalpel, I'm going to make a lateral incision across the site just to get through that first layer of tissue. The scalpel is then immediately disposed of into the sharps. I've already pre-attached a 10mm syringe to my Russell Pneumafix here. Now, gripping the top catheter just below the point at which the syringe attaches and orientating the Pneumafix so that the depth markings are facing towards you. Through the incision you have just made, at a 90-degree angle perpendicular to the chest, we're going to insert the Russell Pneumafix until there is a loss of resistance. The Pneumafix here has a built-in pressure gauge which allows you to visualize the point at which you enter the pleural space, and that's indicated by the small green ticker that should pop away from the patient as you head through. Now, as you get past that and you feel the resistance and it clicks back, you want to make note of the depth that you have on the chest. So here I'm currently at 5 centimeters. Then going to advance a further centimeter into the chest, so from 5 down to 6. And what we're going to do at this point is I'm going to aspirate the syringe at the top of the Pneumafix, aspirate some air to make sure that we have in fact reached the pleural space. Now at this stage I want to start advancing the catheter off the needle, a couple of centimeters, 2 to 3 centimeters. And now I'm going to hold the catheter firmly in place and remove the needle. And this is going to be placed directly into the provided sharps container. This has now been rendered safe. Alright. At this stage we need to secure this Pneumafix. So using ECG dots, half onto the chest, half onto the catheter, and then onto each other. And then moving on from here, we want to bend the catheter towards the patient using a tape hinge. Attach this to the patient's chest to ensure that this isn't going to be moving anywhere at all.